All right, it is 1:32 p.m. We've got about 90 minutes on this panel, and we're really eager to leave plenty of time for discussion. So thank you for the 10 of you, 11 of you who've joined us already. Folks obviously are welcome at any time. And so my name is Jamileh Jemison. I am a director of clinical development at MindMed, and I'm joined today by Dr. Benjamin Silverman, Dr. Francis Shen, and Dr. Lyneise Williams. Today, we are going to be talking about data as misrepresentation, confronting AI bias in psychiatry. And run of show today, we are going, after I give you the run of show, I'm going to do a little thematic context for our discussion. I want to encourage you, so this will be my first plug, to put questions in the Q&A box. We really want this to be a dialogue. So anytime you have a question, just pop it in there. I'll be watching it and can bring it to our panelists and also probably throw it back out to you as well. Then we'll have a presentation of first the brief bio and then presentation by each of our panelists, and we will actually start a little bit of discussion after each presentation, so you don't have to save it all for the end. Hopefully that'll keep it really interactive. And then I'm going to leave 5 minutes at the end for each of our panelists to have sort of a last word on this topic. So as I mentioned, I work at MindMed. We are a company that develops both digital tools and medications for CNS and mental health conditions. I met the panelists, Francis and Benji, from doing TIPS conferences. This is my third one. And then together they organized this amazing seminar this spring through the Harvard Radcliffe Institute for Advanced Study called Intimate Data, Ensuring Justice and Equity as Psychiatry Embraces Boundless Data and Artificial Intelligence to Treat Mental Illness. And that's where I met Lyneise. And the theme of that seminar, where several experts across a wide range of fields, including psychiatry, law, AI, racial bias, ethics, criminal justice, neuroscience, gender studies, political science, and anything else we could think that sort of touched this very intersectional area, all came together to discuss the gaps in the current ethics and regulatory literature, focusing on potential for exacerbation of social inequity through unequal access to these algorithmic tools, and also in the sort of unequal way that they're built. And so that was a really, I think, invigorating experience for all of us. And just some of my takeaways were that there's still many open questions and paths for research and discussion, that we really need to dream better and more inclusively, including thinking about how we change and understand language around diversity and inclusion in this category, how we write about it. You know, I know there's always lots of focus on the problems, but we can find solutions when we keep working on them. And this really important I think, dance where we talk about this, because we haven't gotten this right yet. But we have to operate with the belief that by continuing to discuss it and explore it, we can get it right. So as we kick off here, I want to kind of let everybody a little bit off the hook. I know that anytime diversity and inclusion can come up, it can feel sometimes very fraught, very immediate. The immediate part is great, but it can always feel like, how am I going to climb this mountain by myself, right? This is a hard thing to do. We can all acknowledge that. Well, what that means is that because it's hard, I think we have a moral and practical practice imperative to continuously work at it, and to remember that, you know, tech sort of gets treated as this culmination of where our society is going. But I think we all know that the real pinnacle of culmination and community and civilization is continuing to evolve. So it's with that spirit that I want us to have these discussions and make sure that as much as we take in the times that we've done it wrong, that we're aware that if we keep working at this, we can evolve to do it better. I'm going to keep us rolling and transition into Francis's talk. So, Dr. Francis Shen is a very busy man. He has multiple departmental appointments across Harvard Med School and Harvard Law School, as well as being the executive director of education and outreach at the MacArthur Foundation on Network on Law and Neuroscience. With co-authors Owen Jones and Jeffrey Schall. He authored the first law and neuroscience textbook, which is now in its second edition. And I think this is perhaps the bit of Francis's work that I've interacted the most with, is that he's very strong in interdisciplinary work and regularly collaborates with scholars and industry members in neuroscience, psychiatry, and psychology, and has participated and led many cross-disciplinary workshops on neuroethics and the law, including the Radcliffe seminar we've been referencing from earlier this spring. So Francis, I will give it over to you.
Thank you so much. And thanks to everyone for being here, and thanks to TIPS and to Harvard McLean Hospital for hosting. No disclosures to offer, acknowledge all the various funders. So here's what I'd like to talk about today. I really, as the title suggests, I want to look at what we can do when we start with this reality check, which is that we can talk about how we'd like AI to be developed, but the reality is that many tools are coming to market for mental health care that may not be trained, or that we don't know whether they're trained on sufficiently representative data. So the ethical and legal question I want to get at today is, can you still use these tools knowing that, or maybe not knowing enough about them? And if so, how do we navigate that? So I'll use a real world example, the use of portable neuroimaging, which is something I've been working a lot on, which is heavily reliant on AI. I'll also use a case study, which is something that some of the colleagues here at McLean and I have worked on, which is return of results amidst uncertainty about AI bias. And I'll just offer at the end a couple of very quick thoughts. There's not really time to sort of go into detail on some essential next steps. So let's start with this reality check, which is, I think, really, really important because it's already well known. I mean, many sessions at this conference are recognizing this. There are problematic biases in medical AI, not just race and ethnicity, but others. And there are a lot of good ideas about what you would do if you were starting from scratch. And here's just one from our colleague, Aaron Kesselheim and colleagues. And, you know, you're careful with your data collection and data prep, and you develop your model the right way, and you evaluate it, and you go through the right authorization regulatory processes. All right, so that's the way it should happen. And there are other examples of different models. But it's like this huge but, so it's about the largest font size I could find. Many tools will arrive or have already arrived on the market that did not utilize those strategies and did not train their AI models with representative data. So if this were a different conference, I guess a futurist conference, we'd have time machines, but I'm going to assume we cannot go back in time. There's no TARDIS, there's no DeLorean that's going to hit 88 miles per hour. And if there are no time machines to rewind the clock and redo that technological development, we're faced with this conundrum. What do we do with technology that's AI driven, but that AI driving system wasn't trained on representative data, or we don't know whether it was trained on representative data? So here's some examples. So it could be that the data set's lack of representation is known. So in this example, the developer is transparent and rigorous in assessing, and that was one of the comments, and communicating which types of humans are and are not included in the data. So you've still got the problem, but you're pretty clear on what it is. That might be one example you're dealing with. But it may be that the data set's lack of representation is just not known because the relevant variables were not rigorously measured. And I'm going to come back to this at the end in my next steps. You know, when you look at a socially constructed category like race or ethnicity, and you simply ask someone to check one of 5 options, you're missing a lot. And the analogy I would make to the presentation we just saw from Lyneise is that you know, it's like that really fuzzy archived version, right? If you're not really clear on what kind of data you have, so maybe you don't know what the biases even are. And then it could also be the case, this is happening, that the reason we don't know about representation is that the developer or whoever owns access to that training data set won't tell us the black box, the lid is shut, and we don't know what fed into the model. Now, there are many reasons, some of them quite understandable, why a training data set may not be representative. Some of these I'm going to give you 4 examples. Some are, I think, more and less sort of ethically palatable, and they'll strike you differently. So one is ignorance. The developers simply didn't know that they needed a representative data set. I hope that that is changing, though I'm not entirely sure it is. A second is a little more cynically, but again, this is happening too, and I understand it. There's a deliberate choice to maximize profit. The developer could have done more, but chose not to because it would have raised production costs, and at least in the short term, to use representative samples. Again, it's beyond the scope of this talk, but any of you who do community engaged participant-centered work know it's messy, it takes time, it's costly. It's not the easiest path forward. It's not again, in the short term, the least cost, and so maybe this is one reason. Now, there are other reasons, which are, again, if any of you are startup developers, I'm sure you face this, capacity constraints. So let's say that someone wants to follow best practices, but this developer has, they've already taken out a second mortgage for their tech. They've done everything just to get the initial beta program working that they've got to sell to keep going forward. And that initial beta program was only trained on non-representative data. And this is similar to the last one, which is, hey, it's just pilot work. Look, we just got to make sure, and this is something I hear a lot from engineers, we just have to make sure it works first. Then we'll test it on a more diverse population. Sometimes clinical trials are done this way. Oh, when we get to the stage 3, then we'll get that diverse population. But now just beta testing, so we can just use our convenience sample. So whether it's these or other reasons, this leaves us with a lack of diversity in training data for many of the models I think that we'll hear about here in this conference and that you're seeing in market. And this leaves us with 3 options. When we recognize the reality that we don't have a time machine, we can't go back and change things, given those constraints on the previous slide, here's what we're dealing with in kind of our reality check. So what do? Well, one option, don't worry, be happy, play your Bobby McFerrin and just ignore the fact that everyone in the sample was white and of a pretty high SES. We'll just move forward. It's an inconvenient truth. We'll ignore it. All right. So that's one option. I don't advocate for that, by the way, but it's an option. Another is proceed with caution. All right. We're going to use the tool, but maybe with a more limited scope or with added caution. Of course, there's a lot of gray zone. Like, what does that mean? Then the other extreme is you say, hold up. Not at all. We are not going to use this until you go back and show us that. At least we're not going to use it on all populations until you go back and show us that what your training data is sufficiently representative. And there may be some times when we want to do this as well. All right, so having laid out, I think, the options and the landscape, let me quickly talk about a real world example. I'll breeze through this and then get to a couple things at the end. So I've been working with colleagues at the University of Minnesota, Mike Garwood and Susan Wolf and Francis Lorenz, and then we have a big working group that I want to recognize on the ethical and legal implications of highly portable and cloud-enabled neuroimaging research. You can find out more here, but this image and the graphic at the front kind of captures the idea that neuroimaging is coming out of the lab and into the field, which means we'll get potentially brain scans for everyone, including vulnerable populations, meaning anyone can scan. The idea that you have to have intense training will fade away as it becomes more user-friendly, and brain scans can show up everywhere, home delivery. There are a lot of different versions of this. This comes from a publication we did, and these are different models from different labs. And if you think this is, science fiction, it's not. Colleague at Brown, Sean Dione, has his scan a van. You can go see it in action on YouTube, and they will drive up to homes and they work with kids and scan kids. And to quote from their article, we want to do MRI house calls, and they actually are doing that, right? So it's this sort of combination of digital phenotyping with these models, and it's going all over the world, part of the larger trend that you see at this conference where clinical and research practice was previously constrained, like you got to be right here in McLean Hospital. No, now it can be field-based with the wearables, the implantables, the mobile MRI units and the like. And there are a lot of reasons to be excited about this. You can get on-demand brain scans, you can monitor participants in real life, their social interactions and real-time interventions, more objective data. You can do it a lot more frequently. But one of the challenges, now there are more than just AI, but one of them is that to make those systems work, that Scanavan that you saw, there is heavy reliance on cloud-based AI, ML systems, and there's a potential bias of interpretive algorithms in those diverse populations. This is a diagram we have, a sort of where the data flows. And before it flows back to this, there's a person with a little iPad. They've got their participant or their patient in the machine. That data is going, although the participant and the researcher or clinician are maybe just a few feet away, the data is going thousands and thousands of miles away to be analyzed by the AI system and shot back through the crowd. So the secret sauce is really the heart of this model. And often we don't have access to the representativeness of the underlying data generating those images. This is an example. There are many other examples we could use. And there are particular reasons, I think, to be concerned about this use in psychiatry. So with digital phenotyping, portable MR, you name the technology, they're a two-way street. So we're talking about not just sort of evaluation, but potential interventions. There's a real tension between objective and subjective assessments, and whether it's a digital phenotyping tool or a portable MR, the participant may be telling you one thing, or your patient, but this AI generated system is telling you something different. Can you trust the AI given its maybe lack of sufficiently representative training data? There are other issues which include this, you're collecting data from others in some of the digital phenotyping tools. And this is something we talked about a lot in our seminar. The data you're collecting, whether it's brain data or data giving insights into mental functioning, are really, really intimate. All right, so let's put this together into a case study of conundrum that's happening right now, which is, what about return of results? Now, we're in the state, we're doing tons and tons of research, right? The colleagues on this call and in this conference are trying to figure out how you harness boundless data, not to Scott Rauch, who uses that term, with advancing use of AI to get improved clinical outcomes. I want to cite a great team, including Ben here in this call, and Justin Baker, and a whole bunch of others at McLean, and a huge working group. We've been trying to investigate this for the last couple of years around the issues of computational justice. And here, to make it concrete, is the choice that researchers face. So let's say that they've come to this conference and they're using the tools that you are developing and using, smartwatches, smartphones, AI, the whole smorgasbord. And it turns out that these tools will allow to facilitate return of individualized research results to participants, monthly, weekly, daily. But the research team is not entirely clear what they should do, because the whole point of the research is to build the representative data set, but it's not representative yet. So at what point can they return results based on their AI model? How representative does this data set need to be for purpose of return of results? And this is a really, really thorny question. So we've got a framework and an article that's under review, but I'll present it here with 28 co-authors and really tried to work on this for the last couple of years. This is just a high-level summary, but I'll show you where we are to answer this question. We're in the zone of unknown risk because we don't know enough about the representativeness or lack thereof of the system driving the conclusions offered, but also unknown benefit. That is, there could be really high benefit, we don't know. There could be lower benefit. Again, we're unsure because the research is still ongoing. So I will simply say that there's a lot of gray area here. I'd be against a bright line rule that says you could never return results. You could never not use a system that's not trained on representative data, but you ought to be pretty careful. And most importantly, you ought to specify clearly and articulate what the policy is. So it's not ad hoc, it's thought about before. And that might lead to then additional conversation with the developer, with the manufacturer, with the research team to try and fill in these unknowns, right? They don't necessarily have to remain unknowns if there's early action. All right, so just two thoughts on the end. There's a lot more that could be said, but to keep within time, I want to just mention two things that are really important. And one already came up in the chat. That's rigorous measurement. The other is community engagement. So sustained real community engagement. So on rigorous measurement, I just want to illustrate it this way. All of Us is really set, if you don't know the All of Us research program, it's NIH-driven research program to do tremendous population science, including population neuroscience. And they've done a really nice job of measuring at granular levels of detail these tricky categories of race and ethnicity. And I'm just pasting in for you examples of the way that when all of us researchers engage with participants, they break out these details. And these aren't all of them, but these are some of them, right? So you've got a bunch of different categories within American Indian or Alaska Native. You got multiple categories within Asian. You've got an option to choose other. You've got multiple categories within Black, African American, or African. You've got multiple categories here, Hispanic, Latino, Spanish, and so forth, okay? And there's much more granularity. So that's the way to do it. Now, I'm part of a program recently funded by NIH. Eric Rosenthal at MGH is our leader on this module. There are other modules across the country. And the idea is that the bridge from current sort of data practice to AI in health and medicine has a lot of challenges to address. One of them is the ethical and legal social implications. And just on this issue, so remember all this granularity? Look at all that granularity. Many, maybe most hospital systems, including some in partners, here's how they measure race and ethnicity: white, Black, Hispanic, Asian, multiracial, other. That's it, right? So without more granular data, it would be hard to know if the AI system is sufficiently represented for application to a given population, right? Because again, you've taken this really fine-grained data, and I think back to Lyneise's slides, and you've just simplified it. You've made it fuzzy, right? You've got to unpack that. So that's point one. Point two is that sustained community engaged research is the way to go. It just is. We can talk more about it. And it's the next step that we're taking. Our seminar we met last year with COVID via Zoom will be in person, and we hope to be community engaged with some colleagues, a group called More Than Words. If you're in Boston, check out their bookstore. But these new voices really impact the way that we go about doing this work. Last thing I'll just say is get involved. We're hiring, the lab's hiring. So if you're a student listening to this or a fellow, I hope maybe, and you're interested, you'll come find me afterwards. All right, thanks, Jamileh. I think I stayed pretty close to our time.
That was beautiful. Thank you, Francis, and welcome back, Lyneise and Benji. For more discussion. We have a wonderful question in the chat that's about specific examples. I'm going to throw it out here now, but it can also sort of come back a little bit later. But someone asks, are there some specific examples of AI-based mental health tools specifically that are particularly problematic in terms of serving persons with mental illness equitably? And I mean, Francis, you obviously just gave sort of a case study around imaging, but I'm wondering if anything springs to mind for anyone else in the panel around specifics there.
I think it's a really great question, and I'll talk a little bit about this in my slides, which is, I think the reality is we don't know. And I think the reality is that many of the AI algorithms that are out there likely are operating on variables related to race, ethnicity, and other factors that we actually aren't aware of because they haven't been tested to really understand, from an AI explainability standpoint, exactly why they are operating the way they are. So my fear is actually that the answer to that question is likely many, and we don't actually know.
I guess the two things that I would throw out that I worry about, and this is me just thinking about the landscape that exists right now, and I don't have 6 papers lined up to back this up, but in response to that question, I would say, think about any situation that has an automated chatbot and where the language choices in that chatbot were developed and who they were sort of piloted with and who got to give feedback on those. And one that I think is like extremely exciting for the field, but also could be extremely fraught. There has been this app called Oui, OUI, like the French for yes, that's being developed to be sort of a in the moment redirection crisis tool for folks who have suicidal ideation. And I think, like everybody, it's really exciting that there might be an in-the-moment tool that a person could turn to, and it has showed great efficacy in its early research, which was largely with soldiers. So soldiers may actually be a diverse population, like they could have had a diverse set of folks in there, but they're also culturally going to be a little bit different than other sort of lay people who might be using that. So I think it's a great question, and just I think anything you can think about that's already out there could be challenging because we don't know, as Francis and Benji both said, we kind of don't know what we don't know in some places here. So some other questions. So Francis, I love your talk, and this is one of there's always a couple of like key moments that you always hit on that work with me. But I actually think your opening question and the theme of your talk is really important in terms of separating legally and ethically. Sometimes they're separate, sometimes they can come together. But for you, how are these different, and how does the differences between legal and ethical kind of impact how this work evolves?
So I think that I had some slides that I thought about adding in. I didn't because of time, because of on the law side. So I'll just maybe say, I appreciate the question. Thanks for asking it. And I'll just say that I think liability here and the fear or potential liability for an algorithm gone wrong, or really, a decision made that causes harm in part based on information generated by an algorithm, creates some perverse incentives. I've seen this a lot in clinical decision support making where, and I understand again why it happens, but the maker of the support decision, the AI support tool, will say, we are just providing additional information to the decider. You're still making all the decisions, so sue you, not us. But at the same time, of course, the claim to the decider, to the clinician, the researcher is, our tool is really, really, really good. It's going to help you make better decisions. So I think applied here, the challenge is that there may be both economic and legal incentive not to fully disclose, or maybe not even to measure, because the general standard in tort law is a reasonable person standard. It has a lot to do with the knowledge that one had. And so if I go forward knowing, actually, so this answers the other question. Now, if it's unknown, it's murkier. But if I know that the data set was only trained on adults, and I'm using it on kids, say, the machine to make some decisions about kids, that might be, and then something bad happens to the kid, and we say, you gave the wrong dose because it was, okay, that's a problem. If I, the person who just made that decision, didn't know a lot, right? Got some ignorance there. So I think I think the law intersects with the ethics quite a lot in terms of the liability. There's another world which is it's beyond this talk, but which is talks to the regulation side, the role of FDA in governing algorithms. I mean, it's like a whole can of worms. I would just say that I do think there's actually a role for, I'm interested to hear what Benji would say, for IRB as a lever that can be pulled, and for the FDA to pull a lever, which it has. I think the best analogy is drug development and sex as a biological variable, where for a long time it's like, oh, just use males or whoever you want to, and then give it to everyone. And it's like, wait a second, you can't do that. You need to have equal parts, male, female. I think we should head and have a careful discussion about that in this context. I mean, it's really tough because look at those granular data. Like, do you have to have every subset of, of every race and ethnicity? I don't think so. But right now it's the Wild West. We're not thinking about it. So I think those are the two things that I'd think about in the law, the liability and the regulation side, both of which are not helping a lot right now and maybe hurting.
So well, just one last question that piggybacks on what you were just saying, Francis, because I do, when you put up that slide that showed all the branching, which I think we all think about, and this is for you and everyone, is there going to be sort of personalized AI the way we're trying to get to all personalization, all these other types of medicine? Do we think that's the direction this needs to go? And would that be useful, or maybe not? Like, basically, is there a sweet spot maybe in how granular the data has to be, or how you're looking at things, or do you think it's sort of case by case basis?
I don't know if anybody else wants to jump in. I have a thought, but yeah, I think that you'll get to smaller and smaller groups, but that the precision of precision medicine is still a little dull, and in large part because of the lived experience. I just don't see how you're going to, even with these amazing digital tools, collecting tremendous data. It goes to Lyneise's point. It's a maybe better representation, but still crude representation of a real human being. So no, I don't think you're going to get more precise, but I wouldn't go as far as saying individualized in the way that I treat a human as an individual, if that's the standard. But maybe
Anyone
others
else?
disagree.
Yeah, I was gonna say, anyone else on that? No, I guess one other thing, just because I feel like every single time I go to a conference on anything digital, somebody pops up and goes, "What about digital twins?" And right, and like when people say that in a drug context, there's a part of me that goes, "How is that even going to work?" But I do think that frighteningly enough, certainly any of the big data companies could go and probably concoct a digital twin that is based on one's kind of important market footprint on the web, right? Someone could go and pull, Google could, possibly go and look at all of your data across all the things that they can get and come up with a sort of digital twin of you that, falls into how you use the world online. And would that be a useful thing to test, say, a chatbot against or something like that? This is just wild speculation, food for thought, but.
Well, I think it's a great, I know you're a science fiction person too, and I think it's a great, I don't think it's just science fiction. I think it's really important. But, the example I give my students all the time is just like, one look on a bus or one text can completely change your life. And there's no way that digital twin, even though it shouldn't, it's like, it shouldn't matter. And it can harm your life. It can make you feel crummy for 2 weeks. It shouldn't. It's like, it's just 3 words. Like, why do you care? But it just does. I mean, that's the human condition. So I don't think that's changing. And so again, we're going to get more precise, and digital twins will get us there. But I guess it's a twin within. It's like those movies, right? Where it should work like this, but that little thing changed. To me, that maybe I'm silly. Maybe we're just, we really are that predictable, but we're pretty predictable, but I don't think that predictable. I guess that's my last thought. I'll shut up.
Awesome. All right. Well, we'll take it over to Benji for our last presentation. Dr. Benjamin Silverman is the senior IRB chair at Mass General Brigham, where he oversees the IRB responsible for the review of human subjects research at Mass General Hospital, Brigham and Women's Hospital, and McLean Hospital, among others. He's also the director of ethics for the Institute of Technology and Psychiatry. So, some of the folks affiliated with this conference might know who he is, and serves at Harvard Medical School as an instructor in psychiatry and a faculty member on the center at the Center for Bioethics. So take it away, Benji.
Great. Thank you so much, Jamileh. Thanks for the introduction. And it's really a pleasure to be here today to be able to be part of this panel, talk about this fascinating topic, and talk a little bit about how we're thinking about developing IRB oversight for artificial intelligence in digital health research. I'll start by just, I think, probably summarizing a little bit of some of what we've already talked about in the last 2 talks, to just give you a little bit of the lay of the land of what we're thinking about when we're thinking about the need for new and different IRB oversight of this type of work. So we start with just outlining the awesome potential of digital health powered by AI. And I probably don't need to really repeat all of this for this audience who's very familiar with all of the promise. But some of the items we've talked about, things like adding quantitative and real-time data to clinical care and research, what we were just talking about, the potential to enhance precision medicine or individualized care. I think democratizing expertise, as Francis mentioned, with regards to the portable MRIs, and really, I think that's a big hope in terms of health disparities, is that AI and digital health powered by AI will help with health disparities by being able to improve and scale the availability of care. So really, the idea that this could be a potential solution to some of the bias and health disparities that exist in the medical system. Really, at a whole, the idea that AI would be able to do what people can't do on their own by providing the right care in the right place at the right time to many, many more people than we're able to do so right now. But then on the other hand, and I think the reason that we're all having this conversation is the scary problem of digital health powered by AI. And to just summarize, to say that AI doesn't always work, to say that AI doesn't always work for everyone. So as Francis, I think, really hit on very nicely in his talk, with non-representative data sets, we know that if you train an algorithm on a data set that is non-representative, people who are not represented are likely the algorithm is not going to behave correctly for them when it's applied to them. Doesn't always work in every context, meaning that an algorithm trained on one data set could behave differently when it's moved to a different location in a different data set. And that it doesn't always go through the same independent review process as, for example, other new medical devices do. And this is part of what I'll get to toward the end of the talk, and I think what Francis was just alluding to, that many times there's very little review process actually for some of this, for some of these projects. And so because of these scary problems, it really leads to this potential for AI to cause harm by perpetuating and amplifying societal injustices, exclusion, and bias. So we went from the hope that AI could really help with health disparities and help with scalability and availability of care to the real frightening problem that it could actually make things worse by perpetuating and amplifying bias and injustices. So with that backdrop, I want to provide a couple of different examples. So the first is an example of AI doesn't always work. So this is an example from the OpenAI GPT-3 database that folks may be familiar with, a very, very large database of natural language processing to develop the types of chatbots that I think Jamileh even mentioned as an answer to one of the earlier questions. And it's important to note that OpenAI specifically says this is not meant for healthcare use, which is actually quite reassuring that it's nowhere near the bedside when you read through this example here. But this was a group of investigators and people who worked at NABLA who decided to take the OpenAI GPT-3 database and apply it as a chatbot to a mental health scenario. So this is a person with depression symptoms who is using the chatbot, and you can see on the left side here, the answer ends up being that recycling may help for feeling sadness because of the potential to receive a tax refund, and quote unquote, this makes Americans feel happier because they get more money. And then on the right, you can see where the chatbot unfortunately recommends this person follow through with committing suicide. So a clear example of AI doesn't always work. So that's an AI tool that, again, I think we should be very fortunate to know is not being applied to healthcare right now because it really doesn't work the way one might think it should in this type of environment. And then there's AI doesn't always work for everyone. And so this is a really fascinating study that came out of MIT and Harvard that I want to spend a few minutes on because I think it really highlights some critically important issues, although not in the mental health world. I think the ability to take this and use analogies in our work is really critical. This was work that was initially started because there was a finding that algorithms were consistently missing pneumonia diagnoses in chest radiographs of Black patients more than white patients. So again, AI doesn't always work for everyone. It wasn't working for Black patients the way it did for white patients. And so the investigators on this team wanted to try to figure out why. What was the AI tool looking at that was leading to this difference in the way it was functioning into this bias. And so they used the AI to try to basically ask the question as to whether the AI system could predict the self-reported race of patients from chest x-rays. And they found that, in fact, they were able to train their system to accurately predict about 90% of the time the self-reported race of patients from medical images, from chest x-rays. And the reason that's so striking is that is not a task that is generally understood to be possible by human experts. And what I mean by that is I should be able to hand you a chest x-ray or hand a radiologist a chest x-ray, and there should be no way for us to know what race the person who took the x-ray, the patient who had the x-ray is. It's just not something, the x-rays are considered to be essentially race agnostic. And so the team really looked to try to see what the AI device was picking up. They tried to control for all different types of neuroanatomical things anatomical things that you could imagine might be different from different groups of people. They tried to corrupt the images, crop the images, noise the images, and at the end of the day, they actually couldn't figure out exactly what the AI algorithm was picking up on, which then leads to this Boston Globe headline of scientists find AI can recognize race from X-rays and nobody knows how. And I just want to share another picture from this paper because I think it's really striking. This is where they're trying to noise the images to see to see if the algorithm still works. So on the top here, we have two sets of chest X-rays. On the top row is being filtered through a high-pass filter, the bottom row through a low-pass filter, and then the graph is the area under the curve of how the algorithm is functioning on its ability to predict self-reported race from the images. And so if we start with the low-pass filter, this second row of images, you can see that up until about a low-pass filter of 25 or so, the predictive range stays around 85 to 90%. And that makes sense when you look at the images, because here, the LPF of 150 and 25, they all look basically the same. They look like that same chest X-ray. And so you can imagine whatever the algorithm is picking up on is still there. And then when you get to 10 and 5, perhaps whatever the algorithm is picking up on gets a little bit blurry and it can't see it anymore. So that kind of makes sense. But then we go to the high pass filter, which is really striking. And so if you look at the data on the high pass filter, up until about a high pass filter of 100, there's still a predictive ability of about 85 to 90%. And then if you go and you look at these images, this is what the high pass filter looks like in D and E here at 50 and 100. And so it's striking because when you get to the high pass filter image in letter E here, it doesn't look like an X-ray anymore. If I handed you that image separate from this talk, you wouldn't be able to say that came from that. It's imperceptible that that's still an X-ray. And yet even at that level, the AI device can predict with 85 to 90% likelihood that the self-reported race of the person from whom that X-ray was taken originally. And that's really striking. What does it mean? It means that algorithms, and this is what I was saying earlier in answer to the question of we don't know, I think it means that algorithms, we think that algorithms are looking at very specific quantitative data. We think that we're training algorithms to look at, in mental health scenarios, often step counts and GPS data and physiologic data and lab tests. And we think that we know what the algorithms are looking at. But the reality is they may be looking at things entirely different variables that could include things like race, ethnicity, gender, socioeconomic statistics, and other things that really pose a risk of perpetuating bias and disparities. So essentially to say that algorithms can act on hidden information within data sets. And the part that's really scary about that is that we might not even be able to tell what the algorithm is seeing because we can't see it ourselves, for example, in the chest X-ray example. And what that means is that algorithms can actually propagate bias in ways that we're not understanding right now. And I think that this is really important to note because this is a separate problem from what Francis was talking about with regards to non-representative data sets. I think we, as Francis outlined, we can all, I think we're at a place where we all agree that non-representative data sets are a huge problem and create bias, and it's a huge issue for the field, and more representation is critical. But this is really important to note that even more representation may not necessarily solve the problem of propagating bias and injustice through algorithms. And so with all of that said, essentially, we do need more governance of how we propagate algorithms. Because of time, I won't have time to go into a kind of a deep dive about what developing AI governance means, but just wanted to highlight that there are different types of governance. There's hard governance and soft governance. Hard governance is when we think about federal and state laws and regulations, things from the FDA and other federal regulators. And then soft governance is things like the work that I do at institutional review boards, among a variety of other oversight type of boards. It's worth noting in this box that I show there's tons of emerging AI governance that's out there. I think that we are not alone in having this conversation and realizing that there's a real need for more oversight here of how algorithms are developed and deployed. And so just to talk a little bit about my work and what we do at the IRB, I just want to start by saying this is kind of the current IRB oversight of AI research lifecycle. Right now, the clinical development of AI models is really developed with what I would call standard IRB oversight. There's really absent any specialized or extra review process for model analysis. Many models are developed with retrospective or secondary use data that ends up being considered exempt research or even not human subject research classification. And what that means is that those protocols get even less scrutiny and less oversight. These studies are frequently considered minimal risk as the data are not directly influencing medical care. These are, Francis kind of alluded to, often pilot studies and all of the things where it ends with a clinician who can make their clinician judgment before it influences medical care, often are considered minimal risk because the AI tools are not acting on their own, which is really good and important and a safety feature given given everything that we just talked about. But what it means is that it also shields it from additional oversight and shields it from some of the hard governance models. IRBs rarely right now receive detailed model development or validation details. In part, that's because the IRB application is submitted at the beginning, and many of these things are in the development stages and are created in real time as the model is being completed. And so we usually get very little information actually about how the model is developed. We do consider, regulatory review as part of our review, and we do have to consider at which point in their life cycle models would become subject to FDA oversight, although because of some of these factors I mentioned, a large majority of the projects that we see are not subject to hard governance from either state or federal law. Some of the new laws that are being proposed and passed, these wouldn't apply because those are applying to large corporations, and different financial limits and things. And then the FDA guidelines often don't apply because they are these pilot trials and other things where they're not truly kind of classified as medical devices yet. And so what that means is that a large majority of what's being, I would say, in the research world, being academic research world in medical centers being put forward actually gets fairly little oversight right now. And so what we're trying to do at Mass General Brigham, and this is kind of an emerging model that we have, is to really kind of change the way that we are doing this and really promote transparency and bias mitigation throughout the AI life cycle. So we're looking to really break down in our assessment of AI models each step along the way, from pre-processing to training the data, building, testing, deploying, and the feedback stages, and really developing a system where we have IRB policies and tools to examine and audit essentially at each stage, so that when we're in the initial training data stage, we do data bias checking and bias mitigation. And then again, at the testing and deployment stages, we do model bias checking and bias mitigation. And again, at the feedback stages, and then along the way, making sure that we have essentially AI explainers and explainable AI where we really can understand exactly why the algorithms are acting the way they're acting to try to mitigate some of these risks of propagating bias that we've outlined. So just in summary, to kind of try to wrap up here just with a few thoughts, I think as we're developing IRB oversight for digital health research, I think we really do believe that the current safeguards are inadequate to protect against the risks of AI. Fully recognize the tension between regulation and innovation. I'm sure that when I show the last couple of slides, there are people who get a little bit anxious about what that IRB process could look like with more regulation. But just to say that I think we are fully aware of this and really want to strike the right balance between regulation and innovation. I think it's just so critical to keep that in mind. This obviously requires necessary expertise. We're very fortunate at Mass General Brigham to be part of a large academic medical center and to have a large IRB where we can bring in the necessary expertise to do this type of algorithmic auditing. I know that's not the case at many IRBs in the community, and really a separate argument could be made about whether this is an IRB role or should be another institutional role, but either way really requires the necessary expertise and requires people like you all who attend conferences like this to join us in these efforts. And toward that end requires collaboration between all of us. I think between scientists, researchers, clinicians, ethicists, IRBs, regulators, legal experts, institutions, and most importantly, our patients and community members, to make sure that we do achieve the right balance here and to make sure that we're doing this the way that we should be. The need for ongoing oversight is critical. These models, as you all know, don't, it's unlike a study where you design the protocol and it doesn't change, and it kind of, the protocol is the same at the beginning and the end. You know, these models evolve, and so there's need for ongoing oversight in a way that we don't offer right now. And then I think, you know, the real reason that I think this does fall into to the IRB oversight, at least at academic medical centers, is that I think independent review and accountability are essential. And I think that's what IRBs really have to offer. You know, there's, as I mentioned in that previous slide, a lot of AI governance conversations going on, a lot of talk and a lot of conversations. And the question that I asked when we had our Radcliffe seminar was really, you know, where's the accountability? How do we kind of turn that talk to action and really try to start, you know, as the question that was raised at the beginning here, you know, is it too late? Well, we've got to start somewhere. We have to start doing this work and actually doing the more thorough assessments. And so, you know, in order to do that, you need a body that has authority in order to have accountability, and that's something that IRBs can have in the context of academic medical centers. Really, the idea just to make sure that we're doing this the right way. So I'll wrap up there so we can have some more time for discussion. I do just want to do a few acknowledgements. I really want to acknowledge and thank my friend and colleague, Danella Como. Dr. Como is an IRB vice chair with me at Mass General Brigham, is co-chair of our DEI advisory committee, and helped me with the slides for this talk, gave me some slides for this talk. I wish she could be here as part of this conversation, but is to her credit, fortunately out of the country right now. And it's just been a wonderful support in helping us really lead this effort at Mass General Brigham. Certainly acknowledgement to Francis, who's been a wonderful colleague as we've done this work together as kind of co-I for this Harvard Radcliffe Institute for Advanced Studies seminar that we pulled together. And then we do want to thank all of our Radcliffe seminar participants, including Dr. Jemison and Dr. Williams, who are so gracious to join us here today to continue this conversation. So I'll stop there and look forward to more discussion.
Thank you so much, Benji. It's a great presentation to conclude on the parallels with the imagery between the first and our last presentations. And then, of course, you gave some great advice. So we have at least one question and a really wonderful comment. So thank you. So Benji, I think you actually spoke to this a little bit in your last slide, but you know, you mentioned that MGH is in good shape and they've got a lot of tools to do this. So how do smaller groups like universities, smaller IRBs across the US follow suit and maintain these high standards?
Real challenge. You know, as like many facets of the world, IRBs tend to be understaffed and under-resourced and don't necessarily have access to this expertise. But I will say that, you know, within the IRB community and world, that there are people who are very knowledgeable about this and really trying to work on this. And so, you know, I think like if I were at a community IRB, first thing I would do would be to reach out to people like me and others in the IRB world to see what resources we could share. I think IRBs tend to be very good about, you know, nothing is proprietary. If I have a form or a process by which I've developed to do auditing, happy to share that with other IRBs. So I think trying to rely on that community is certainly part of it. Yeah, I think that's the best probably advice I could give. You know, I think that is a challenge, though, that this is not easy work to do.
So I feel like we probably only have time for one more question before I give each of you a moment to put in any last words. But I think this actually ties a little bit of this together. So Benji, you can kick us off if you want to, but I'm interested in how Lyneise and Francis, you see this. How, like, do we have any concern that the oversight that is needed, right, either to make sure that data sets are inclusive or accurate, or to understand that there's things that the models are doing that we didn't know, do we think that the need for oversight is going to slow down research? In any way, both research that improves the tools we're trying to make and research to get new tools out there?
Right. I mean, this is something I spend lots of time thinking about and talking about in every part of my job, basically, in terms of the tension between regulation and innovation, and how slow that process can be. And I think it's always a concern. What I tell people is, I'm pro research. I wouldn't be doing my job if I wasn't pro research. I think there's often a misnomer that maybe IRBs try to stand in the way of research or slow things down or things like that. But in fact, that's not the case at all. The case is that I view myself as part of the research community. I'm pro research and just want to help people do research in the right way, right? And so I guess I think it is possible that doing this type of auditing could slow things down. But I guess what I would say in response is, but that should be a good thing, actually, right? Because doing research faster to get to a tool that either harms people or isn't equitable or doesn't help people the way we want it to, that's not really good research anyway, right? So what are you rushing toward? And that gets to Francis's point that there's all kinds of other, other incentives that people may have that are pushing them. But that's kind of my stance on it. Is I think that slowing it down will make it faster to get to the research product that we actually all want.
Awesome. All right. Well, it's just 5 minutes left in the seminar. So I think this is a good time to turn it over to any last thoughts folks wanted to share.
And I can maybe, pick up on what Benji was just saying. So I don't know that I would use the word slow, slowing the research, but I think it changes the research, these sorts of things we're talking about. And I do think it changes the distribution of benefits and probably the distribution of profits. So that matters to a lot of people, and everyone doesn't agree on what those things should look like. But I think it's really important, I guess more than anything in my view, and the questions that I raised, even if they're unknowns, just to be upfront about those and to be intentional and clear in what someone's going to do. And we didn't talk as much today in this panel, and I understand why, about the benefits of these AI tools, but they're awesome, potential awesome benefits. I mean, like really good ones. Like look at all the rest of the panels in this conference. So I'd agree with Benji that this is not here to put a brake on research or to say, no, don't do it, or always go back to the drawing board. But it is to say there are so many historical examples where the combination of enthusiasm with a sort of laissez-faire attitude towards these questions has just proven disastrous, and especially for the marginalized community. So I guess I just leave it at that. And I would just echo again what I said, if anyone's interested in this stuff, you're listening on the recording or live, track us down. There's a lot of work happening. We need more help. Thanks. And thanks, Jamileh, for wonderful moderating.
Thank you.
That's great.
Benji, any last thoughts?
I would just echo Francis's comments, and thanks to Jamileh for this wonderful moderating, and to Lyneise and Francis for joining on this panel and this journey. And really would just say, we're neck deep in this work and need help and want your help and collaboration. So whether you agree with everything we said, you disagree with everything we said, welcome aboard. Would love to help, love to have you join the IRB, love to join Francis's research efforts. I think please get in touch with us. And thank you for being here and listening.
Thank you to everyone who stuck with us. Thank you to my panelists and conference. It was a lot of fun. Get in touch with any of us if you want to continue the conversation. Take care, everyone.
Thanks, everybody. Bye.